Hi, my name is Chiang. I'm an interventional radiologist in the Department of Radiology at UCLA, and I'd like to talk to you today about microwave ablation of the liver. So what is an ablation? An ablation is a minimally invasive, image-guided procedure used to treat early-stage liver cancers. This is a percutaneous procedure, meaning that the needle just goes right through the skin, into the liver, into the tumor itself. Energy comes out of the tip of the needle to raise the temperature of the tumor to temperatures greater than 100 degrees. At this temperature level, no tumor cell is going to survive, and all tumor cells within the ablation zone are effectively eliminated. Because this is a percutaneous procedure, thermal ablations can usually be done in an outpatient setting, meaning that patients can come in, get their procedure, recover, and go home the same day without any need for overnight recovery in the hospital. There are many types of liver cancers that are amenable to ablation. Usually we divide liver cancers into two categories, primary liver cancers and secondary liver cancers. Among the primary liver cancers, the most common is hepatocellular carcinoma, which is a tumor that grows in the setting of chronic liver inflammation. And this can include alcoholic cirrhosis, hepatitis B, hepatitis C, or non-alcoholic hepatosteatosis, or fatty liver disease. Another common form of primary liver cancer is cholangiocarcinoma, which is a cancer of the bile ducts. For secondary liver cancers, these usually arise in the form of metastatic disease from a separate primary cancer, and these cancers include colorectal, lung, breast, pancreatic, melanoma, neuroendocrine, or gastric. So what ablation modalities exist today? There may be many that you've seen from other institutions. Among the thermal ablations, we typically divide them into heat or cold-based ablations. Among the heat-based ablation modalities, the common ones are microwave, radiofrequency, laser, or high-intensity focused ultrasound. Among the cold-based ablations, they include cryoablation, which is like an ice ball. Worldwide, the most common ablation modalities used today are microwave and radiofrequency. So why do we use microwave ablation? Well, radiofrequency has historically been the most commonly used ablation modality worldwide. Radiofrequency ablation uses a point source of heat and allows the heat to dissipate passively through the tumor tissue. Because the heat comes from a point source, the heating takes a lot longer and sometimes necessitates multiple applicators to actually sufficiently treat the tumor with adequate margins. Microwave ablations, on the other hand, can heat tissue temperatures to levels much higher than that of radiofrequency. In this image on the left, you can see the temperature comparing radiofrequency with microwave ablation. The blue line is microwave ablation, the red line is radiofrequency ablation. On the y-axis is the temperature, and x-axis is the time. And you can see that the microwave temperature far exceeds that of radiofrequency ablation after only a short amount of time. For that reason, microwave ablation can heat tissue more homogeneously and at a faster rate compared to radiofrequency. And we can also create larger ablation zones compared to radiofrequency ablation. That's the reason why we use microwave ablation more commonly at UCLA. So how do we decide who gets an ablation? The first thing we do is we review the cross-sectional imaging with a dedicated liver protocol, CT, or MRI. We then bring the case to our tumor board, where we discuss the case in conjunction with our transplant surgery, hepatology, and oncology colleagues. We discuss everything from the underlying liver function to the number of tumors, to the size of the tumors, and also the patient's functional status, or how well they do their activities of daily living. A clinic visit is then arranged with myself or my colleagues to discuss the risks and benefits of ablation, evaluate the labs to see how the liver is doing, and also a physical exam to see how the patient will tolerate an ablation procedure. So how do we actually do an ablation? On this image here, you can actually see a cross-section of the liver, which is a slice of the liver. You can see that this is the liver, and this bright object here, that's the actual tumor. A patient is brought down to the table, and on ultrasound guidance, you can actually see the liver and the tumor. Under a combination of ultrasound and CT guidance, An ablation needle is placed, again, through the skin into the liver with a tip parked inside the tumor itself. Under ultrasound guidance, you can actually see the ablation zone being formed around the tumor. After the procedure, we perform a contrast-enhanced CT scan to make sure that the ablation zone has encompassed the tumor with no viable tumor. The procedure is done at this point, and the patient can go home and recover at home. At 1 month, they come back and they see me in clinic, and they get regular surveillance after that. What happens to the ablation zone? Well, normally what we see is that the ablation zone involutes on itself, and at the end it just becomes scar tissue. What's the recovery like after an ablation? This is, again, an outpatient procedure, so people can walk in and go home the same day after the procedure. This can be done under either moderate sedation or general anesthesia. Microwave ablations are generally tolerated very well with minimal to no discomfort. There may be some mild bruising or skin sensitivity where the needles have been placed through the skin into the liver, but those usually resolve in a few days. There is a phenomenon known as post-ablation syndrome, which can occur in up to 10% of patients. The way it presents is with fevers and flu-like symptoms for up to 24 to 48 hours after the ablation. This usually resolves on its own, but patients can take over-the-counter medication if needed. After the ablation procedure, we usually schedule a 1-month follow-up clinic visit with MRI. The idea of the 1-month follow-up visit is to confirm that the ablation treatment zone has adequately encompassed the entirety of the target tumor. We also want to confirm that if there were any discomfort after the ablation, that it has resolved by the 1-month follow-up. We also schedule a follow-up visit every 3 months for up to 2 years afterwards. The idea for this surveillance frequency is that if there's any residual disease, we can treat it again with ablation very quickly. If there's no evidence of recurrence after 2 years, then the frequency drops to once per year after that for regular surveillance. So in conclusion, microwave ablation is a minimally invasive, image-guided procedure used to treat early-stage primary and secondary liver cancers. It's associated with a quicker recovery, fewer complications, and virtually no bleeding compared to surgery. This is an outpatient procedure, so people can come in and go home the same day without the need for any overnight stay. Most importantly, getting a microwave ablation does not prevent you from getting any additional therapy, meaning you can get additional ablations, additional transarterial therapies, and additional systemic therapies if you need it. By getting an ablation here at UCLA, you will also enroll in our cancer surveillance program with follow-up MRI 1 month after the procedure and every 3 months after that for up to 2 years. And with that, I thank you for your time. If you have any questions about ablations, please feel free to contact the UCLA Interventional Radiology to schedule a consultation with myself or one of my colleagues in the Interventional Oncology section. Thank you.